Welcome to Adult Healthcare NU 623, Unit 3, Presentation 4 on Asthma, Chronic Bronchitis, and COPD. Ensure that you fully read your text for additional information. You're not going to get everything you need to know in this lecture. I also encourage you to review any resources that are listed in your course module. First, we're going to discuss asthma. These are the symptoms that you might see either alone or in combination with your patient who's presenting with a possible diagnosis of asthma. The symptoms are usually going to be worse at night or early in the morning, but there's going to be no symptoms typically between attacks. And I'll let you read over these yourself. I'm not going to read them all to you. But I would like you to look at the last two, allergy symptoms and eczema. You're going to notice a correlation between atopic type of diseases, allergies, and asthma. When you're working up a patient for suspected asthma, your clinical history and findings need to be correlated with the diagnostic testing. Typically, the first test that's going to be done, which is widely available in most clinic offices, is a spirometry test. And you're going to want to do a pre and post bronchodilator test in the office. If you can't get the results that you need, they're unequivocal or it's a difficult interpretation, you can do further testing with full PFTs, but this usually has to be done at the hospital. You also want to consider allergy testing because of the high correlation between allergy and asthma. Peak flow monitoring can be done in the office, but it would be important for a patient to already know their baseline peak flow values. But this monitoring can be ongoing at home. Methacholine challenge is not typically done in a primary care office, and you could refer out to that if your PFTs were unequivocal. Chest x-ray does not need to be done to diagnose asthma. It could show normal, or it could show some changes such as hyperinflation or bronchial wall thickening, or even diminished peripheral lung vascular shadows, but it is not necessary. Asthma classifications are listed in your text. I want to make sure that you read through those thoroughly. I'm not going to go over them, but you're going to need to know them in order to provide the proper treatment plan. One other thing I'd like to say about spirometry testing is the difference between your pre and post bronchodilator numbers. In order to show reversibility of airway obstruction, which is a diagnostic criteria, the FEV1 reading has to be 10% or more increased post bronchodilation. Also remember to rule out your other differential diagnosis. And in your course module, there should be a link to some other resources that will help you to understand spirometry testing and how to interpret the results. In your management of your patient with asthma, like I said earlier, the first thing you have to do is determine the classification of severity so that you can start them at the correct treatment level. There's a stepwise guideline treatment flow chart that will be on the next slide. It's also in your book on page 401, and you need to follow that. That's evidence-based care. You want to do aggressive approach to treating asthma because of the long-term effects and the chronicity of the disease. You want to make sure that you remove any exacerbating factors. In other words, make sure there's no smoke or secondhand smoking. Make sure you have removed all the allergens that you've identified. Your patients should always have an asthma action plan, which is a written instruction to manage acute attacks at home. They have to be provided with intensive education about the disease process, the progression, the complications, how to handle an exacerbation, proper medication use and adherence, as well as the side effects of the medications, and ensure that they are receiving the proper immunizations that are required. The drugs that are commonly prescribed in asthma are detailed in your text on this page in this box. I want you to look over that very carefully. This is heavily tested on your board exams. The types of drugs that can be used are your SABAs, which is your short-acting beta-agonist, LABAs, your long-acting beta-agonist, your ICS, which is the inhaled corticosteroids, and your LTRA, which is your leukotriene receptor agonist. Cromolyn, theophylline, and systemic corticosteroids can all be used. Your SABA is always going to be your rescue inhaler. The remaining ones will be your maintenance. medications, systemic steroids can be used both long-term as a burst treatment for an acute exacerbation, or they can, like I said, be used long-term. Here is the treatment flow chart for asthma. As you can see at the top, you have your classifications of severity of asthma, which you would have obtained from the symptomology of the patient and your PFT or spirometry test results. Start the patient wherever they're at. If they're in persistent asthma classification, then start them at step 2. If they're severe, start them at step 4. If they just have an intermittent asthma, start them at step 1. You step up to the next level when there's no control over the symptoms. And then once you have control for at least 3 months, you try to step them back down. So you're only going to use the highest appropriate therapy at the time to gain control. You're going to want to review this treatment plan every 3 to 6 months with your patients. This is the asthma exacerbation action plan, which you would communicate to your patient. It is a self-management basis, and it goes off of the peak expiratory flow rates. You can find this in your text on page 402, as well as the previous slide you can find in your text on page 401. Now, your patient must know their baseline peak flow first, then they can proceed to the proper course of action when tested during exacerbation. This chart will give them the treatment options and the red flag signs and symptoms and what level of care to seek for resolution. Follow-up for your stable asthmatic patients would be every 3 to 6 months, and as needed to educate the patient or their caregiver about disease and management. For referrals, you would think about an allergist and or a pulmonologist for patients who have severe persistent asthma, a life-threatening exacerbation or hospitalization for asthma, and patients who required more than 2 rounds of oral steroids within a year. They may be candidates for immunotherapy. Obviously, your hospital referrals would be for patients whose exacerbations are not well controlled on home medications or respiratory distress. This is the presentation you're likely to see with your patients with COPD and chronic bronchitis. These are the most common symptoms. Persistent progressive dyspnea. If they have severe disease, they'll have paroxysmal nocturnal dyspnea. Cough and or sputum, and know that they will have colored sputum and increased production during the exacerbation of chronic bronchitis, along with a fever. Also understand that patients often underreport their symptoms. On exam, you're likely to find, if it's an early disease process, it could be completely normal, or they may have prolonged expiratory phase or wheezing or on forced exhalation. As the disease progresses, increased resonance on percussion, decreased breath sounds, wheezes, crackles in the lung bases, and distant heart sounds can be heard. In severe disease, you'll likely see a barrel chest, and in end-stage disease, they'll be in a tripod position, which helps support the function of the diaphragm and eases breathing. The gold standard for diagnosis of COPD is spirometry with bronchodilation or PFTs with bronchodilation. Quantification of the percent of reversibility after bronchodilation is no longer recommended. On spirometry, if you have an FEV1 FVC ratio less than 70%, this is your diagnostic criteria for COPD. Chest X-ray can be done to identify potential comorbidities or to rule out other etiologies, but it's not necessary for diagnosis. A CBC can be done to check for anemia if dyspnea is present, polycythemia, which could occur with chronic hypoxia, or infection for bronchitis. CMP would be used to check electrolytes, liver, and kidney function, and your BNP if you're suspicious of heart failure. An EKG tracing can show atrial arrhythmias, which are common in patients with respiratory disorders. A PPD might be done if you're worried about tuberculosis, and you definitely want to check a pulse oximetry. If you have less than 92%, you should check an ABG. Testing for alpha-1 antitrypsin deficiency should be done in patients who are younger than 45 degrees and whose spirometry results demonstrate COPD, but they have minimal or no smoking history or a family history of COPD. In a bronchitis exacerbation, you can do sputum cultures, but this is rarely seen in the outpatient setting. Make sure you go through the differential diagnosis list and understand the differences between COPD and these other disorders so that you know the proper workup and how to rule them out. The gold standards or guidelines are your evidence-based practice model for the treatment of COPD. You can find this resource online, or there should be a link in your course module. Treatment algorithms are based on the FEV1 that you're going to get off of spirometry or pulmonary function test, and the exacerbation history, which are all available in the GOLD guidelines. You're going to start your patients on a single or a combination bronchodilator therapy. If they have persistent symptoms on a single agent, you're going to increase to 2 bronchodilators. PDE4 inhibitors can be used. Oxygen therapy for patients with a SAT less than 88% or at 88% if they have pulmonary hypertension, heart failure, or polycythemia, which is categorized as a hematocrit greater than 55%. Patients with asthma and COPD sometimes have overlap syndrome, and they can benefit from long-acting beta agonist inhaled corticosteroids combinations. You want to make sure your patient definitely quit smoking and that they are up to date on all of their recommended vaccines, the annual influenza vaccine, the pneumococcal conjugate vaccine if they're older than 65 or equal to or older than 65, and the pneumococcal polysaccharide vaccine if they're 19 to 64 with chronic health conditions. Pulmonary rehab is indicated for all patients to decrease symptoms and improve functional status. This chart can be found in your text on page 415, and it offers a holistic viewpoint of the care of a patient with COPD. In an acute exacerbation, you will use bronchodilators. You can use the short-acting beta agonist with or without a short-acting muscarinic antagonist. You're usually going to use these in the MDI format, so you'll do 1 puff every hour for 2 to 3 doses, and then every 2 to 4 hours as needed. Patient may also have to be on systemic steroids. We usually do a burst treatment with this. You do a high dose of prednisone, 40 milligrams for 5 days. There's no need to wean at that level if you're only giving it for 5 days. Antibiotics are controversial, but they're supported when you have clinical signs of a bacterial infection. Early COPD, you're going to use amoxicillin, clavulanic acid, or a macrolide or a tetracycline. And if you have more advanced disease, these patients usually have Pseudomonas, so they're going to require a quinolone. Also, those patients who have repeated exacerbations or resistant pathogens or have had mechanical ventilation, you really should undergo sputum testing to identify the pathogen. Your follow-up timeframes for patients with COPD are going to depend on their severity of their disease. If they're unstable or they have severe disease, you're going to want to follow them monthly. If they're stable, you can bump it out to every 3 to 6 months. If they've had a hospitalization, you're going to want to see them within 1 month of discharge. It's a good idea to do annual spirometry to monitor the disease progression. If they are going to be on theophylline therapy, you're going to need them see them every 6 to 12 months because they're going to need blood draws to monitor that therapeutic effect. If they're on oxygen, ABGs should be done every 6 months or when there's any change in condition. As far as referrals, your main referral is going to be to the pulmonologist. You'll want to send them there if there's a suboptimal response to the therapies while you're giving them appropriate treatment, and you're making sure that they are adhering to their medications and using their inhalers correctly. They may need case management, a social worker, or home health care if they have limited resources and they're functionally declining. And then, of course, you would send them to the hospital for any exacerbation that's not controlled or signs of respiratory distress. Again, please read your text fully. Everything that you need to know is not necessarily in these presentations. Also, check out the resources in your course module.